Guy Clifton, neurosurgeon and health policy reformer, among other things, to campus for our discussion today. As many of you know, St. Ben's and St. John's and the Benedictines have a very long history of health care, particularly in central Minnesota, and I think the sisters especially, having started 7 hospitals and returned the vast majority of them to the communities as a gift. Our own St. Cloud Hospital, those of you who are St. Cloud staff members know of their history. And we have a very strong and thriving nursing program at St. John's and St. Ben's. It's a small and very selective program where our goal is really to develop and send out leaders in the profession. So this is a perfect setting for these kinds of conversations. This event, as many of you know, is made possible through the work of the College of St. Benedict and St. John's University McCarthy Center for Public Policy and Civic Engagement. Though the center is fairly recently established, it has already had a tremendous impact on our campus communities, the lives of our students, our alums, and the community broadly. The McCarthy Center encourages constructive debate and engagement in community affairs through its lectures, internships, fellowships, and committees, and its residencies at a time when our nation needs more than ever to listen to the voices of young people and embrace their creativity and insights. The McCarthy Center strives to build connections to alumni by engaging graduates to mentor current students, and also seeks to serve as a resource for the greater policy community at large, which is why many of you are here today. I look forward to these dialogues that are about to occur, and thank you to our guests, our wonderful guests, and thank you for the rest of you joining us here today. I hope you enjoy. Thank you.
Welcome, everyone. My name is Matt Lindstrom, and on behalf of the Eugene J. McCarthy Center for Public Policy and Civic Engagement, I want to welcome all of you today. This is, as Marianne mentioned, the 2nd annual McCarthy Residency here at St. Ben's and St. John's. We're very pleased to host Senator Durenberger this week. Before I continue, we have a couple prizes to give away. Every 5th person that sent in their RSVP won a free signed book today. So I don't know if Noreen Dunnels is here yet. I think she's the only one that's not here. But the 5th person to RSVP is a familiar name, Mr. Troy Fritz. Is he here? This is not a rigged deal either, so don't even start. And then we have Joan Vincent. She is here. Veterans Affairs, Public Affairs Office. Thanks, Joan. And Beth Honkamp. Is she here? There we go. There we go. And Professor Matt Byrne. So there you go. Lucky you. Yeah, right. Well, you can buy one too. You can buy one too. So, Senator Durenberger has spent the last 30 years as a public servant. He is twice elected to the U.S. Senate, and at the U.S. Senate, Senator Durenberger found his passion in health policy as the chairman of the Health Subcommittee of the Senate Finance Committee. His service in this increasingly important field of health policy is can be no doubt understood through the importance placed upon hospitality and taking your neighbor in as Benedictine values in the Rule of St. Benedict. Since leaving the Senate, he has been named Senior Health Policy Fellow at the University of St. Thomas, where he chairs the National Institute of Health Policy at the Opus College of Business. And while in residency this week, Senator Durenberger has been very busy. He's been to nearly 30 separate events, class visits, a Rotary talk, interviews with the media, several panels, and so forth. So hopefully some of the students here have been able to take in some of those. The bookend, though, of his residency will be a March 16 event with Vice President Walter Mondale and Gary Eichten, which will be taped for broadcast on Minnesota Public Radio. So mark that on your calendars. That'll be a public event. So now Senator Durenberger will introduce our guest, Dr. Guy Clifton. So thank you.
And thank you all for being here, especially thanks to the students and the faculty at St. Ben's and St. John's, because this should be, after 30 events in 3.5 days, I should really be dragging, but I'm not. I'm high as a kite. It's just a tribute to all of you. I have really, really, really enjoyed my homecoming, and I look forward to coming back if I'm invited. But I'm going to introduce Guy Clifton, whom I met in Washington, D.C. when he was a substitute speaker to my MBA class, and we take a seminar class out there. And Guy was, when Guy got up, he gave, he gave the speech that the guy that was supposed to be there and couldn't make it gave, and then he went to the Q&A, and when he got to the Q&A, he was a totally different person. And I thought, wow, this guy is really good for a neurosurgeon in particular. I mean, I didn't know they had personalities. Anyway, he's a professor of neurosurgery at the University of Texas Medical School at Houston. He was the founding chairman of the neurosurgery department, holds the Runnels Distinguished Chair in Neurosurgery. He's listed, was in 1996. He was already listed in Best Doctors in America. He's internationally recognized for his clinical research in the treatment of severe brain injury, and the principal investigator of a multinational study of hypothermia and the treatment of severe brain injury. And he's also an expert on what it's like to be a trauma neurosurgeon in this country today, and he's written about that in this book. He was an RWJ fellow in Washington, D.C., sort of changed his career path a lot because he got so immersed in the role that policy plays in bringing out the better as well and the best, rather than what we're currently getting out of our healthcare system, that he decided to use that, go to the New America Foundation, and write the book that you've already been introduced to. So it's my pleasure to introduce you now to Dr. Guy Clifton and welcome him here today. Guy, thank you.
Thanks so much for having me here, and thank you, Senator Durenberger. It's getting warm Minnesota hospitality, but the weather's not warm. His comment about neurosurgeons, my daughter's a communications major. She's 30 years old, has an MBA in acting from some school in England. And she said, Dad, you're going to have to express feeling. I said, honey, I don't have any feeling. She said, you have to find some. So I've been getting coached on empathy. Anyway, it's a hazard of being a neurosurgeon. I'm going to go off script a little bit. I talked to one of the professors, and when I started looking at, well, let me tell you why I'm here, first of all. I was chief of neurosurgery at the University of Texas Medical School in Houston and Memorial Hermann Hospital, which is probably one of the two biggest trauma hospitals in the country. And the mental picture of this is big hospital in the middle of a large medical center, 6,000 hospital beds, helicopters flying over the fourth largest city in the country out to rural areas and suburbs, bringing in patients with mortal injuries, hemorrhages in their brain, broken necks. And there are only two trauma centers in Houston. They're both very big and very busy. And I had been in that position since 1990 and built a large department based on doing a good job every time, taking every patient every time. In about 2001, the ground started shifting under my feet and our feet. You know, we think that life goes along, things don't change. But if you can see what is happening in the banking system right now, sometimes things do change. Then systems began to fail. So what I found myself is in the middle of a really spectacular system failure in Houston, Texas. And so what would happen is I would be on call on a Sunday talking to a doctor from a rural area and saying, I can't take your patient. We have no bed. I don't know what to tell you, but there's no place to put this patient. And for 10 years, I'd never had that conversation with anyone. We always had a bed. We could always take patients. And I thought this was odd. And over time, what happened is within 6 months, I began hearing stories from the trauma center across the street. Couldn't take patients either. Well, there weren't any others. We were it. And within another 6 months, both of the trauma centers were saying, we can't take your patients 30% of the time. A colleague of mine, I cued him in, did a study of this and found out that the mortality rate from severe injuries in the area was increased 50% on days when both trauma centers were diverting ambulances at the same time. Well, I raised a bunch of money, hired people from California to come in and look at what was going on, got involved with the Texas legislature. We actually got a bill passed that provided some money. What had happened was this. Without me knowing it, or anyone really knowing it, the uninsured rate in Houston had risen to 30%, 1/3 of the population. And at the same time, the hospitals, the emergency hospitals, they're required to take any emergency at any time by federal law. You can't even ask. So what the hospitals were doing was admitting the same percentage of uninsured that existed in the population. The problem is the books didn't balance. 70% insured, 30% uninsured doesn't make for a profitable hospital. So what the hospitals had done, not by colluding, but just a series of multiple decisions, many of which I'd been involved in, frankly, to essentially cap the number of intensive care beds. So what had happened in that region is the population had increased 20% in a 10-year period, and the number of beds, kinds of intensive care beds needed for these patients had actually fallen. So it was below community levels. Now, the work that I did and others did gave the area a respite, but right now in Houston, Texas, it's the same story. And we found out, for instance, if you're in one of the counties around Houston, 5 million people in that area, you have a 15% chance of laying in the bed of a small emergency room with a serious problem, a heart problem, a brain problem, needing to get into a large center for care and having to wait over 8 hours to get there. 15% chance. If you're out fishing, walking, golfing, and it's an equal opportunity offender. The insured and uninsured are equally at risk. So what happened to us was that the uninsured rate had become so high that there was literally system failure. Now I thought, this can't just be Houston. Well, if you look around, Los Angeles is in the same boat. One of the two reasons Arnold Schwarzenegger pushed universal care in our coverage in California was emergency services failure, and the other was what's done for hospitals to balance their books. When you have high uninsured rates, they push the prices to private payers up, thought to represent about 8% of healthcare premiums around the country. In Houston, it's 16%. So those were the twin reasons that California drove for what it was doing. Anyway, as time passed and I began to look at this whole picture, I came to understand that the biggest obstruction to covering the uninsured was probably the cost of health care. And I'm going to talk to you a little about that. And I've geared this talk to the students because you're the ones that are going to have to, I'll be dealing with it, and all of us in this room will be dealing with it, but you're going to be dealing with the, if we don't fix this, you're really going to be having a problem. This is the cumulative growth per capita in private insurance, Medicare, compared to GDP since 1970. And what we are now, why now? I've been hearing that health care was too expensive since I was 25 years old. It really is now. We're on the wrong end of the compound interest curve. You can't have a segment of the economy growing at double the rate of GDP, which is what health care has done, for 30 years and have it keep on going. It's unsustainable. So why is it unsustainable and why is it 8 years? Because I think we have 8 years. Right now, when you write your income tax check, 11% of it is Medicare. In 2020, when you will all be in the workforce, it's going to be 21%, and by 2030, it's 34% of the federal budget. By 2050, there's no federal budget left. It's all Medicare and Medicaid, which can't happen. So we've got about 8 years to turn this around. The reason the uninsured rates are so high is also primarily cost. There are a number of insurance issues. But this is Lynn Nichols' slide, my colleague from New America. In 1987, when the country had 12% uninsured, a family could purchase, or their employer could purchase, health care for them at about 7% of the median income. It's now up to 17% of a family's median income for health care. And that's, again, the compound interest curve, because wages have not risen at the rate that health care costs have risen at. When we talk about reforming health care, this gives you some idea of what we're looking at. I've gone to calling it the medical industrial complex, like Dwight Eisenhower called the military industrial complex. This is 17% of GDP. Housing is 10, food is 10, national defense is 4.6. This is the single largest segment of the U.S. economy that we're talking about changing. So hold your breath. So the cost issue is this. We're going to have to cover the uninsured to deal with the system issues that are now threatening everybody in Houston. That's one reason. The other is the uninsured cost is shifted to private insurance by hospitals. It's part of the problem with health insurance premiums. And the third is Catholic social justice. which you're no stranger to, and that is, let me give you the picture of what happens if you're one of the 47 million uninsured. You have access in most states to primary care, a reasonable level of primary care, that is a regular doctor. But if you need a heart scan, you need heart surgery, you need cancer surgery, it is unavailable. 1.2 million people in Houston, and those surgeries are not offered. That care is not available. One MRI scan for 1.2 million people in the city. And it's not that different in Los Angeles and Tucson and Phoenix and Atlanta and most other cities in the country. So there are really three reasons we have to do this. Now, so what's the problem? Well, the problem is 100 to 120 billion a year, and that's going to be the cost of covering the uninsured. By the way, these are working people. 85% of the uninsured are in working families. They're mostly low-wage workers. Most of the increase, and this should make you nervous, in the last 10 years, the number of uninsured has been in the middle class. The percentage in the lower income group has been stable for years. So we're now, this is solidly in the middle class right now, and I think that the recession or whatever we're in may make this worse. So where do you get $100 billion? And that's where the cost of health care comes in. We really, the way I think about health policy, or came to think about it, is the insurance issues are one set of considerations which I'm not going to get into. But I will just say that the reason insurance is so expensive is delivering health care is so expensive. If you get the cost of delivering health care down, insurance will go down. Now, there are a lot of issues of pooling, accessibility, can I buy insurance that have to be dealt with. That's insurance reform. I'm talking about now what is called delivery system reform. That is changing the way we practice medicine. That's where the money is. So here's how not to control health care costs. This is what we've done since 1962. This graph is private per capita national health care spending. That is the cost of private insurance, and this is the rate of increase of private insurance each year. And what this goes on to show, and I'll show you what it is that every decrease in health care costs that's occurred over 50 years has been price cutting. That's all we've done. Volume has risen without control. So what happened, Medicare and Medicaid were implemented in 1966, and employers' retirees were offloaded, so their costs dropped 3%. This is cost escalation per year. It's back up to 7% in no time. In the Nixon administration, for the first time, wage and price controls were applied to the entire economy. And medicine fell to a negative growth rate, healthcare cost did. It's up to 8.3%. And the Carter administration told hospitals, get your cost structure down or I'm going to do it for you. The voluntary effort went down, back up to 9% growth per year. This is inflation-adjusted figures. Then managed care in 1994. This was actually a precursor to the emergency services failure that spread like a virus around the country. What happened there is there was a recession of 1990, and employers said, we can't afford these health care costs, and essentially insurers consolidated. Prices were driven down about 30%. There was a hospital financing problem, and then hospitals began to close their door to emergency patients and uninsured because they couldn't afford it, and that's persisted to this day. Point is that what you get with price cutting is ER failure, decreased access. Medicaid patients, for instance, the doctors are paid about 69% of what Medicare pays. You can't get a Medicaid patient into a specialist's office in Texas. They go to public clinics. Decreased quality, and I won't get into the quality problems, but from 30,000-foot level, the U.S. healthcare system has got some serious quality issues. And you only get a temporary effect. Volume goes up. So the only choice we have that will improve quality, the only way we can decrease healthcare costs in the United States that will improve quality is to improve quality. There is no other alternative. And so my thesis is going to be that if we develop a high-quality healthcare system, we can cut our costs dramatically and afford to cover the uninsured, and that's really the subject of what I'm going to talk about. I think there are three ways you do it. First, this is not just a doctor problem. The public's going to have to help, and what the public is going to have to do is anchor themselves to one primary care doctor as their first point of contact with the healthcare system. I'll tell you a little bit why. I think the second is we're going to have to change the way we pay providers. Right now, I was paid for how many neurosurgical cases I could do regardless of the outcome. A neurosurgeon with a high reoperation rate makes the same amount of money as a neurosurgeon who gets it right the first time. And then the other is we're going to have to establish benchmarks for quality medical practice. That is, we're going to have to define what is quality, because we don't have good measures for what quality is. If we do those three things and we can implement them in a way that we can practice medicine well, then I think we can get exactly where we need to be. Well, where's the money? Well, here's the money. Turns out that there's about 40% of what's done in the U.S. healthcare system is pure unnecessary services. That is conservatively $700 billion. Now, you can cover the uninsured for about 100. So the point I'm making is we've got the money to cover the uninsured. The healthcare system certainly doesn't need to get up to 20% of GDP. We need to wring the unnecessary services out of the healthcare system, and we can use the money to cover the uninsured, and we may need it for some other things, it's looking to me like. It's in three buckets, and they're mutually exclusive. One is inefficient hospitals. I was a creature of hospitals for 30 years, and my estimate was 25% of what we did was probably unnecessary. If you look at hospital-acquired infections that are preventable, medication errors, and just lax processes in hospitals, it's a lot of money. Now, this is a guess. I can't give you a figure here. I've asked people who make their living as consultants for hospitals what they thought. One said 15%, the other said 40%. I think it's about 25% of hospital spending, which is about 30% of all healthcare spending. Poor management of chronic diseases, this is a huge one, and no health economist really disagrees with this figure. 30% of healthcare spending. Where this came from is this. If you're a patient with heart failure and you live in Miami, the doctors in Miami are going to apply 2.5 times more interventions to you than doctors in Minneapolis. They are going to admit you to the hospital rather than manage your heart failure at home. They are going to send you to 2 or 3 cardiologists rather than handle it themselves. They're going to order tests, minor procedures, not major procedures, but they're going to do a lot more things. Now, it's interesting, in high-spending regions of the country, 2.5-fold in the extremes, patients report less access to care and have actually slightly higher mortality rates. So it appears that low-spending areas of the country in management of chronic diseases are higher quality spending areas of the country. What characterizes a high-spending area? Lots of hospital beds and lots of specialists. Now, people don't get in a back room and say, we're going to practice bad medicine. Nobody does that. It is really culture. It's culture and supply. When you're in an area with a large supply of doctors, specialists, and a large supply of hospitals, imaging centers, they're going to get used. Empty hospital, this is not a market. An empty hospital bed gets filled. Everybody knows this. A CT scanning center, usually owned by a physician, does not go idle. It gets used. And so people simply use, within appropriate practice of medicine, very different indications for taking care of patients, and it's very regional. And it's actually cultural, I think. And you know what? I practiced in Houston, which is one of the highest spending, lowest quality areas of the country, along with Louisiana and Mississippi. I didn't know this. I didn't know that we were doing anything different than anybody else until you started taking a look at it. But the astounding variability in health care, everywhere you look within a hospital, between physicians, between states, between cities, it's about 250% risk-adjusted variability. That's the range of variability in health care. And the other, and what I was going to, I'm unpacking my talk a little bit for tonight. I'm going to talk about something here in a minute that I won't talk about tonight. Unnecessary procedures. Now, that's very interesting to me because I made a living doing procedures for 30 years. And I did some calculations, and my calculation that about 6% of hospital spending is procedures that, if they're not unnecessary, they're of absolutely unknown benefit in the patients that receive them. So so how do we, let's go back to this. If this is right, how do we do it? The reason to anchor yourself to a primary care doctor is the 30% chronic disease. Right now, the average Medicare patient has 7 doctors. In high-spending regions, 30% of Medicare patients see over 10 doctors at one time. Nobody could possibly know what's going on. And so the only way that we're going as a nation to reduce our health care costs is to have a doc that you see. Have you ever wondered why, if you call your doc, if you have a doc, at 5 o'clock on Friday evening, the answer is, if you have an emergency, call 911? That was not the case 20 years ago. You could reach the doc on the phone. When I was a kid, John Hall, we never went to Houston to see a specialist without talking to Dr. Hall, who referred us. That is not the case anymore. What has happened is the primary care docs are having to see a patient about every 7 minutes, 15 minutes, in order to make a decent living, and their patients are seeing, who knows, innumerable numbers of other doctors. So the only way this is going to get managed is for people to allow one doc to take care of them. How bad could that be? Somebody that you could reach 24/7, that knew you, that knew what specialist to refer you to. And I'm not going to get into how we pay providers because I'm going to talk about that tonight, but what that means is to accomplish what I just described, the picture of medicine, the payment system is going to have to be different. We're going to have to pay doctors to essentially keep you healthy, or a surgeon in my case, to get you through an episode of hospitalization with the minimal number of complications. There are ways of doing that, but it's a very big change in how we finance health care. And finally, the benchmarks of quality. That's the one I'm going to talk to you about in a little more detail. And this is kind of a talk for surgeons, but, you know, I think it's interesting. Maybe you will. This is regional variability of surgeries. I mean, if there was a right way to do, right indication for an operation, there shouldn't be a lot of variability. Now, this is surgery for colon cancer, and there's a 2.5-fold regional variability. Now, this is probably having to do with demographics, because there are no relative indications for surgery for colon cancer. If you have that, everybody operates on you, and they should. So this is not a place where there's any dispute among physicians about what to do and what not to do. So this is baseline, and this 250% is probably justifiable 250%. I'm going to show you 1,000-fold variations in a minute. This is carotid endarterectomy. Now this, I'm going to show you this operation, but this is boy, this one works. This is, you have 2 big arteries in your neck, one on either side. And if there's more than a 70% blockage in one of those arteries, and you've had a stroke or you're having symptoms of stroke, if that blockage is removed surgically, your risk of having a subsequent stroke over 5 years is decreased by 35%, an astonishing effect. You're 1/3 less likely to have a stroke if you have this surgery. If you have a 70% blockage and you're feeling fine, then you have a 5% less chance of having a stroke if you have surgery. Now, what became very important is it worked out in a series of very large studies that if your surgeon had a 3% mortality rate or complication rate or below, then in all conditions, whether you were having stroke symptoms or whether you were walking around with no trouble, in all conditions, you needed to have that surgery. You benefited from that operation. The trick, though, is if you were a patient walking around without complications and you were operated on in a hospital or by a surgeon with more than a 3% mortality rate, you didn't want that operation. You were worse off for the encounter. Well, so this one we know a lot about. There are no gray areas. We know who needs this surgery. We know when they need it. We know who should do it. There's not a lot left to imagination here. Well, this is the regional variability in carotid surgery in different communities. The top dot is Beaumont, Texas. Lafayette, Louisiana. These are surgeries per 1,000 population. So in Beaumont, Lafayette, Munster, Indiana, and Houma, Louisiana, it's 5 to 7 surgeries per 100,000 population. Drop down to Honolulu, which, by the way, on anything you look at, you want to live in Honolulu. I don't know what's there, but they don't break their legs. They don't need surgery. Someplace. Pueblo, Colorado, Bronx, and San Jose, it's down around 2. So it's a 1,230% regional variability in the performance of an operation that we know a whole lot about. What is this about? That's the surgery. What this is about is people using indications that don't fit criteria. In 10 states, a group went in and said, let's look at the complication rate of carotid surgery. And what they found is in 6 of the 10 states, the average complication rate of surgery was over 3%. It was in the range of 5 to 6, which means that, for the most part, the average patient that underwent surgery in those states didn't benefit from it. So what this means is people are using very different indications for this operation. What would we do about it? Well, what you would want is your hospital to know these results and to report them. You would want to know this information. You have a right to know, whoever's doing this, I would like to know what your results are. So this is a place where we know what to do, but we don't do it. I'm going to slip over to coronary catheter procedures. This is the bottom. This is a 1,000-fold difference in incidence. Let's go to this. Okay, this operation. This is a procedure that is now replacing cardiac surgery, and what it is catheter is put in the groin, run up to the heart, and when there's a blockage in the heart here, a catheter dilates the blockage, or a stent is put in. Now, people present with heart disease in one of two ways. They present having a heart attack, or they present with what's called stable angina. And that's I'm walking down the street, I get constriction in my chest, if I sit down, it goes away. And those are the two ways it presents. So when there's a blockage in the heart, what's done now, cardiac surgery, open heart surgery is diminishing rapidly. And it's diminishing because of this operation. That's a good thing. Okay. Here's the regional variability of that operation. In Davenport, Iowa, it's 24 per 100,000. Alexandria, 21 per 100,000. Baton Rouge, 7.52 per 100,000. Now, the regional variation in coronary artery disease is 30%. So here's what's going on. If you're having a heart attack, you want the cardiologist to put these catheters in right away. You want them to do whatever they want to. If you've got stable angina, the literature says this, that if you have the procedure, that you do not have a decreased rate of heart attack, you do not have a decreased rate of hospitalization, you may have some improvement in your chest pain. Now, I've talked to friends who are cardiologists, and they will tell you that, well, the latest data is that there's about a 13% difference in medication and surgery for chest pain. In other words, if you get the catheter procedure, you're 13% more likely not to have chest pain later on. So there's this is procedures of marginal benefit, or when these are done for stable chest pain. Proven benefit is heart attack. You want them done. The point is, the top one, marginal benefit, since 1996, these have been about twice the rate of the others, 500,000 procedures done. I presented this to a rheumacardiologist and said, and people started shaking their heads, you got this wrong. And so I talked to them later. So you're telling me 500,000 people a year with stable angina need the procedure? Well, no, we're not telling you that. Well, who does? And the answer is they didn't know. And they didn't know because it's never been looked at. This is a place where we don't have the information to know what we need to know. Now, this is a big deal. This top procedure is 2.4% of hospital spending, which would fund the entire children's health insurance program in the United States, one procedure. So the point is, there are places where we know what to do and we don't do it because we don't measure it, we don't report it. There are places where we really don't know what to do, and this is one, because we haven't looked at enough detail to detect one patient from another. That, I think, is all I needed to say, but that's under the benchmarks of quality. You're going to hear a lot. Things are going to happen in Washington. You are going to hear doctors, and you're going to hear commentators, and you're going to hear people say, they're telling us how to practice medicine. Now, you can't get between a doctor and a patient, and anything I'm proposing doesn't get between a doctor and a patient. But we're going to have to reorganize how we practice medicine. We're going to have to change how we pay doctors in hospitals, and the light's going to have to shine on this whole system. for it to be a quality healthcare system. The question is how you achieve it. And it's not a question of if you do it. The only alternative we've got is to wait 10 years and then be subject to probably another round of severe price cutting, which is going to really, you'll see, it's going to look like the banking crisis. So we've got about 8 years to do this. You're going to hear a lot of things. This is the process that we have to go through. Questions? Yes, ma'am.
Minnesota is very proud to say that all of our healthcare is nonprofit. Have you seen a difference between a for-profit motivation and a nonprofit motivation in these kinds of issues?
There's none. If you look at the rate of uninsured care nationally, for-profit hospitals take care of exactly the same percentage of uninsured patients as not-for-profit hospitals. If you look at quality issues, for-profit hospitals are about the same as not-for-profit hospitals. There's no functional difference. Yes?
How different is it with the Canadian healthcare system as compared to here in the United States?
Ooh.
I know it's a really good question.
Ooh. They're better on every... The international comparisons of health care are all primary care based. In other words, if you look at all the measures in comparison, they're what is the death rate from coronary artery disease, pulmonary disease, and the death rate is essentially what they call primary care preventable. In other words, medical interventions improve them, usually at the level of the primary care office. We're 19th out of 19 countries. Canada's 3. So what is not measured on any international comparisons is the quality of hospital care, the availability of high-tech procedures. I think we probably do. I think the reason healthcare is so expensive in this country is technology and its over-application. We do far more kidney and liver and pancreatic transplants. I think my judgment is would be other countries do too few. That said, go to Calgary. They have a 2-week waiting period for hip and knee replacement. These stories about long lines, I think, are really trumped up. They've done a lot about that. It's a pretty regulated system, but it works pretty well. I think that we have to build on the healthcare system we have, just because of the size of it. The idea that we could throw all this over and start over anew, I don't think we have time for it. I don't think we ought to know how to do it. I don't think we have the political will to do it. And I don't think we ought to try it.
Can you elaborate on that? What you actually mean when you say we need to build on what we have?
Yeah.
About payers, or are you talking about care?
Really care. I think 2 things. It's pretty clear there has to be reform of the insurance industry so that anyone that wants to buy insurance can buy it at the same rate if they're ill as someone that's healthy. It's pretty clear that insurers have to be able to offer you insurance if you want to buy it. It's pretty clear it's got to be made affordable, which is going to mean subsidies for purchase. That just has to be. There are pooling issues. I mean, one of the problems insurers have is they have cut-up markets. That is, small businesses and individuals are in such small pools that one sick person costs them a lot of money. So the job really at the national level is to aggregate large numbers of patients into one pool, and the Obama administration has proposed something like this. So that's why I say we have to build on what we've got. The single-payer system, which that works quite well in Canada, the biggest problem with that is Medicare. Medicare is a single-payer system, and it's going to bankrupt the country. That's where I say we've got to change how we practice medicine. The only way we can get Medicare costs down that is going to improve quality is to essentially manage patients in a coordinated fashion. If we cut Medicare prices, there's going to be a terrible medical care access problem. We're really at the limits of price cutting for the most part. So when I say we have to, I think we have to do with what we have. We reform insurance on one hand, reform how we practice medicine on the other. And it's got to be reformed for Medicare patients, private patients. It's going to have to look the same for everybody. Yes?
How do you do, number one, when we have a 7-to-1 ratio of specialists to primary care providers? So how do you provide everybody with a primary care doctor or whatever? And you're saying doctor, I think so doctor
Well, what we've done in this country is devalue primary care. It's been devalued by the fee-for-service payment system, which is $50 for a 15-minute visit, regardless of results. It's been devalued because people see multiple providers. And so if you do two things, I think we can get primary care back. One, we're going to have to pay primary care doctors better, and two, patients are going to have to listen to their doc. They're going to have a doc and listen to the doc. It's going to have to change. Everyone I know in medical schools that train young physicians tell me that if you can get the income level about 30% of where it is, which is 1/3 to 1/5 of what specialists make, that the vaults will open, that young medical students that want to go into medicine are going to go into primary care. They don't expect to make what cardiac or neurosurgeon do, but they expect a reasonable income. So there probably are going to have to be some workforce supplements. We're going to have to do a little more than we're doing. And I say physicians, the whole trick is having accountable levels of care. Everything I'm talking about, or going to be talking about, is making hospitals and specialists accountable for an episode of care. They are paid by and monitored to deliver efficient, good care. Primary care physician is paid to percent of the savings, if you will, keep people out of ERs and hospitals unnecessarily. 15% of adults are admitted to hospitals for preventable problems, 30% of children. Those need to go away. That's the biggest part of our ER problem. So I think if we get serious about reconfiguring how we do primary care and how we pay for it, I think the problem's going to take care of itself with a little help. I hope. Yes, sir.
You see as the role of the individual in containing costs. You talked a lot about
Yeah.
the system and all its problems, but we are not a real healthy country, and we like, having lots of tests and procedures and going to the doctor and we're saying, what's the role of the individual in the cost?
Well, I think the party's over. I think everybody has to sober up. When I would see patients with, it's really a change in thinking and culture. I mean, and you can talk, yeah, obesity is a problem and smoking is a problem. But we know that when a doctor really seriously talks to a patient about smoking and obesity, it has an impact. It doesn't get rid of it. But I would see a patient with a back strain in my office. Occasionally they'd get through the front door and I'd have to see them. They'd pull their muscle. I'd say, you've just pulled a muscle and you need to take it easy for about a week and it'll go away. I want an MRI. Well, you really don't need an MRI, but I want an MRI. Yeah, let's get you an MRI. You want it with contrast or without? You think I wouldn't do it? So there's some malpractice issues here that have to be dealt with as well. What I think is that we develop benchmarks of quality and doctors that adhere to them can't be sued for failure to diagnose, which is about 1/3 of malpractice suits. You're going to have to do that to get doctors to comply with this. But what the public's going to have to do is say, I will go through my primary care doc to get to a specialist. Now, if it's done right, that primary care doc can tell you who the most efficient, lowest complication specialist and hospital in your region is, and may have a financial reason to refer you to them as well as an ethical reason. And that's how medicine was practiced 20 years ago. I mean, the doc that took care of my family knew who was good in Houston and who was not. So I think it's being willing to say, I'm not going to talk to the neighbor who just had surgery and find out who did his surgery when I need it. I mean, you don't know who you're seeing anyway. There's got to be, you got to anchor yourself to one person. I think that's the best. If you've got other ideas for what the public can do, I'm all ears, because this is going to take everybody. This is not just a physician problem.
Well, it seems to me when the consumer starts paying part of the bill and part of the complexity of the insurance system becomes a little more, there's more transparency there, people start to make different decisions around consumption when they have to pay, say, 25% of the bill or have a high deductible plan.
And I think you're right. I would do the high deductible a little differently than it's done right now. It's applied to everything, the first $5,000 of care. The problem is you don't know if that first $5,000 of care, how badly you need it. And the data is pretty clear that if you're poor and have a chronic illness, you forego needed care as well as unneeded care. If you're healthy and wealthy, you make pretty good choices. But what I would do is, for instance, if we knew that medication was as effective as coronary angioplasty that I talked about for treating a specific patient. I mean, we're going to have to know more than we know now. Medicine was a lot cheaper, didn't act quite as fast. That is to say, it took 6 months to get the chest pain effect with medication that you get with a catheter procedure, and you wanted the catheter procedure. I would say apply the first $1,000 your deductible to that procedure. Now, if you're having a heart attack, there's no deductible. The doc does whatever they need to do. So if we knew enough to be able to grade procedures as highly effective, relatively or marginally effective, or ineffective, then I think you can apply the deductible to those things. Or if you wanted an MRI scan that all the literature and the standards said was really not needed for a back sprain, you can have it. And yeah, insurance will pay for half of it, but you're going to pay the other $1,200. You could even index it to income levels. I mean, you couldn't do that to somebody that was poor, but you could, you know, you could index the amount. I like the principle, just the application needs to be more sharp. It's too blunt. That would be my thought. Yes, sir.
Thinking, you know, ask a step further. This morning on the way up here, I saw a nice billboard that said 5 out of 5 doctors recommend you eat vegetables. Blue Cross Blue Shield have. We're still talking really not about health care, but we're talking about sickness and disease and injury and prevention. What can we do to back this up so people don't even need to or feel the need to get into the system at the levels they do because we are encouraging more self-reliance and more mindfulness of what we eat and so much is preventable.
It is preventable. I think it's culture. I think we've got to get over the idea that none of it matters, that we can have it all. I mean, it's going to have to be. I saw this in the 90s. I mean, it didn't affect the public, but we all were told there are too many specialists, not enough primary care docs, not enough hospital beds, and everybody told us that, and we believed it. And guess what? Hospital beds got empty. People went to their primary care doctor until the public said, "We're having none of this." Now, I will not say that it was well done, but I think it's. I think you got to get the word out to people. Now, I think primary care has a role. For instance, if you're a guy my age and you have a cholesterol of 250, you want to be on a statin. Boy, the literature is really clear that decreases your rate of just about everything. And if you have mild hypertension and it gets treated, and it's now effectively treated exactly half the time. If it gets picked up early and treated, you're not one of these people in the ER with a hemorrhage in their brain or a heart attack. So it's a combination of healthy living, but also having a provider engaged in keeping you healthy, I think. Yes?
When you were talking about transparency, I think one of the things that patients would find is that there's not a lot of transparency in finding a doctor and their track record. And if you do, I mean, there are things out there, but it's very difficult, and it really doesn't tell you much.
There's George Isom, who's with Health Partners, clued me in to, it's in Minnesota, and I can't, do you know where it is?
Minnesota Community Measurement Project, and it's a voluntary agreement by the 100 largest healthcare providers in the state to voluntarily report adherence to conditions where we know we have identified best practices. So if their patients are on a statin, if you have a hemoglobin A1C 4 times a year for your diabetes, healthcare organizations voluntarily report this. You can actually find results on the web if you go to Minnesota Community Measurement Project, and I believe there are now, I think, 50 or 100 conditions that we voluntarily report adherence to best practices.
And I went on it. I went on their website about a year ago, and my mother, who's 88, she would know. I mean, now I also went on the Hospital Compare website. I actually could not find. I finally got frustrated and just bailed out. And then somebody told me how to do it. I went back. Hospital Compare reports all the quality measures and I finally went back and found it. But, you know, Mom doesn't know what an ACE inhibitor is. And it wouldn't mean anything to her. But this collaborative is, did you get vaccinated? Did you get the right medications? That's what we need to do. I can give examples, but I mean, when in primary care, we've got the benchmarks. We know what to do. This is specialty care, we're not there yet. And you could simply say, this doc hits the 90th percentile on all the required, on all the tests. That's all you need to know.
Since they began doing this, they are now beginning to see that docs, I'm a physician, and we look up to see where we fit, because docs don't want to be outliers, and they're beginning to see physicians changing how they practice, because we know the benchmarks are there, we know what we're supposed to be doing, and we know what our colleagues are doing. We don't want to be outliers, and so just the effect of publishing those measurements is going to have a positive effect on getting physicians to comply with best practice.
That's a really important point. I don't want you to think, when I presented this stuff, that I want to tell any doctor not to do a carotid endarterectomy on any patient that they think they need it, because I do not. I do not want somebody doing that to me. I think it's bad medicine. However, it's been over and over and over. If you provide docs with, if you have enough information to know what you're talking about, I mean, you really have studied the issue, you know who needs what, the physicians agree to the standards, you provide that information to docs, let them know what they're doing. They self-correct in a hurry. Nobody, I've seen it in our own hospital, no one likes to practice outside norms. What we have now is no norms. And therefore, it's hard to report to the public because we don't have anything to report to them. Yes, sir.
Looking at number 3 and kind of following up with that, who would you say should decide exactly what those norms are, what that benchmark is, and how do you implement that? Because obviously there are some people whose ox is going to be bored to some extent as you go and do this. And there's a lot to be gained or lost by who decides.
Yeah, the whole business of taking $700 billion out of a $2 trillion system, somebody's ox is going to be gored in a big way. Anybody but the federal government is my answer. I think we need a public-private partnership with a board of people who have absolutely no conflict of interest. They might be physicians, they might not be, they might be business people and consumers. But I think we need a board of people. I think it's a physician-driven process so that you go in and try to find out the right information, construct it in the right way, the medical profession agrees to it. Nobody's ever cut the check to do this work, by the way. I mean, what we know, like all this data on carotid endarterectomy, this is NIH funds that just happened to go that direction by chance. So there's been no focused effort, but anything but the Department of Health and Human Services. The problem with that is, I learned that anything that's in either the control of the administration or the U.S. Congress is a political issue. And if it can be gotten to, it will be gotten to. So this has got to be outside government, though it is absolutely going to take federal funds.
If I may, I just want to add a dimension to Jim's very good question and your very good response, which is, in the old days, when the incentives were right, in communities like the one you're in now, Minnesota, Wisconsin, North Dakota, and so forth, where the doctors in multi-specialty groups particularly were basically self-insured, or they owned a health plan. You mentioned Health Partners as one of them.
Great. Yes?
I'd like to know your opinion of the VA healthcare system.
You know, 2 years ago, I got a phone call from a friend of mine who's an anesthesiologist. We worked together in Houston for years. And he said, he had my cell phone. He said, "You're not going to believe this. I'm in Charleston." I didn't know it, but he had gone to be chief of anesthesia service at Charleston VA. He said, "We had to bring a patient back for a carotid endarterectomy," the thing I was talking about. He said, "I just pulled up. I'm sitting here looking at a screen. I've got this patient's entire medical record. I know his heart function." He gave me specific details. "I know everything about this patient in 5 minutes." He said, "I never saw anything like this." So everyone that's looked at it puts Intermountain Healthcare, Geisinger Clinic, Kaiser Permanente, and the VA as some of the best integrated healthcare systems in the country. Pretty good. And that's a good illustration of what I'm talking about. Has nothing to do with whether it's a government program. That argument is one I don't even get into about whether it ought to be government or private. It doesn't matter who pays, it's what you pay for. And the VA is an example of paying for the right stuff, as far as I can tell.
We have maybe one more question. We want to give you time to visit with Dr. Clifton, and hopefully somebody will buy his book, or all of you buy his book, and he'll autograph it for you, I'm sure. But does anyone have one last question like that? If not, Guy, thank you very, very much.
Enjoyed it. Thank you.